So as you can see here, I'm talking about non-statin therapies and cardiovascular and stroke reduction. These are my disclosures. All right, and we've already talked to you a little bit about this today. These are the guideline recommendations. As you see, we have the ACC 2018 AHA guidelines. Those were the guidelines that came out after ACC AHA took away all targets, and then you had to treat with moderate intensity to high intensity statin medications per groups. 2018 brought back a threshold less than or greater than or equal to 70 milligrams per deciliter. That required you as a practitioner to point blank get more aggressive. It's meant to be a stop point that if your patient is at 70 milligrams per deciliter or any point greater and they're a very high risk ASCVD patient, you as a practitioner need to do more. And that's why they put the word threshold in there instead of target, because it's a stop point. If it's even at or 1 point greater, you need to get more aggressive. Then you saw the 2019 European guidelines come out with greater than 50% reduction in LDL for your high-risk cardiovascular patients. For very high risk, we want your LDL to be less than 55 milligrams per deciliter. If you have an event within 2 years of having a target of less than 55 milligrams per deciliter, guess where we want your LDL to be? Less than 40 milligrams per deciliter. In 2017, who knew our endocrinologists would become more aggressive than anybody else out there? In 2017, the endocrinologist said if you had very high risk ASCVD and you were a diabetic, we target your LDL less than 55 milligrams per deciliter. So thank goodness, 2022, in the fall of 2022, ACC consensus pathway came out listing very high risk ASCVD patients, target LDL less than 55, just high risk and LDL less than 70. So as you see here, we're pushing the limits, we're driving that LDL down lower. Joe Miller showed this to you before. Running a lipid clinic, people always come to me asking me for clinical pathways on treating patients. I think the ACC consensus pathway got it right this time. Both primary and secondary prevention is listed here, and it's an easy algorithm. It's an easy pathway. Plus, it puts into perspective facts to consider. The cost of therapy is a big one, and how to manage side effects. And then down at the bottom, you get considerations in appropriate patient groups. So this is a great algorithm for those wanting to implement more of a standardized process in their clinics. So I always tell everybody, you want to assess the risk and determine the risk category. You want, depending upon where their baseline LDL is, you want to treat them and utilize every tool in the toolbox. So these are your lipid-lowering therapies. We've already talked about statins. Remember, statins are still your first-line agent. So if your patient comes in to you and says, I got on the internet and I read all about the statins, I don't want to take a statin, you can put them on ezetimibe, but you're not going to be able to get them approved for anything else unless they try a statin first. So statins are still the first line therapy. We're going to talk a little bit about ezetimibe, your cholesterol absorption inhibitor. I'm not going to spend any time talking about your bile acids, but we're going to talk about PCSK9 inhibitors, ATP citrate lyase inhibitors, and your small interfering RNA. So this is a little bit about ezetimibe. It decreases cholesterol absorption in the small intestines. Great thing is it's 10 milligrams, one dose only, with or without food. You take it either 2 hours before or 4 hours after bile acids. Side effects: upper respiratory tract infection, diarrhea, arthralgia, sinusitis, pain in the extremities. It can be used in combination with your statin. So your mean percent reduction in monotherapy is 18%. When you add it to a statin therapy, you can get up to 25% reduction. It is not recommended in patients with moderate to severe hepatic impairment. There's no data with pregnancy and lactation. It is generic, so a 10 milligram dose should be very cost effective. Some of the Medicare plans, the Part D plans, do have it as a higher tier, which is very unfair to our Medicare population. But you as a provider just call the insurance company, ask for a tier exception, and it goes down to the lower tier very easily. Or you can give them the GoodRx card, and they can get it at Publix for $15 a month. So we now have outcomes. This is one of the reasons why ACC/AHA came out with their 2018 guidelines, because this was the first medication in combination with a statin that provided us with non-statin cardiovascular outcomes. We have IMPROVE-IT in utilization with simvastatin 40 milligrams in the ACS patient population with an LDL relative risk reduction of 6% in 7 years on CV death and major coronary events or stroke. We also have SHARK with simvastatin 20 and ezetimibe, reduces LDL, shows 17% relative risk reduction in major ASCVD events, 25% relative risk reduction in non-hemorrhagic stroke, and 21% relative risk reduction in arterial revascularization procedures. So let's talk about ATP citrate lyase inhibitors. This is bempedoic acid. It inhibits cholesterol synthesis in the liver. It increases LDL receptor density, so bempedoic acid is activated by, is a prodrug and needs to be activated by ACSVL1 in the system, which is expressed primarily in the liver. It's indicated to decrease LDL in adults with ASCVD or HeFH as adjunct to diet and max tolerated statin therapy. Once again, one dose, 180 milligrams daily with or without food. It can be combined with ezetimibe, mean percent reduction in LDL, combination therapy with statin. You get 17 to 18%, so with statin and Zetia, you get up to a 38% reduction. Big side effect is increase in uric acid levels, so those who have had gout, you want to tell them that they may increase their gout attacks. There is drug-to-drug interaction, so concomitant therapy with simvastatin greater than 20 milligrams or pravastatin greater than 40, you do want to avoid. It does require a prior authorization, and for your Medicare population, it could be expensive, up to $200 to $300 a month. This is really just essentially everything that I mentioned in a green, yellow, red slide to tell you what to be cautious of. This is a mechanism of action. You can see ATP citrate lyase inhibitors work 2 stages up from your statins. It is a prodrug, so there's no active ingredient in the skeletal muscle, which decreases myalgias in your patient population. In excretion through the kidneys, through the O2 system, this is why you have the increase in the uric acid. This is clinical effectiveness, which we talked about just a little bit ago. but I'm going to go on to the CLEAR outcomes, which were presented at ACC in March of this year. This is primary or secondary prevention patients with an LDL greater than 100, randomized to bempedoic acid versus placebo, 4-component MACE, CV death, non-fatal MI, non-fatal stroke, or unstable angina hospitalizations, and secondary endpoint was 3-component MACE, CV death, MI, and stroke. Greater than 24 months. And you can see here the reduction. You have the placebo at the top. You have bempedoic acid at the bottom. And you can see the great reduction HSCRP using bempedoic acid here. And of course, we have the cardiovascular outcomes. So you have 13% relative risk reduction in 4-component MACE, 15% relative risk reduction in 3-component MACE. You had 23% relative risk reduction in fatal and non-fatal MI. You had 19% relative risk reduction in coronary revascularization, 15% relative risk reduction in fatal and non-fatal stroke, and you had 34% relative risk reduction in hospitalization for unstable angina. There was no statistically significant difference in cardiovascular death or all-cause mortality. And this is one of the first outcomes trial that was predominantly done in your statin intolerant patient population. So we do think that Asperion's going to go back to the FDA and ask for a statin intolerance indication for bempedoic acid. PCSK9 inhibitors, so this is alirocumab and evolocumab, binds to PCSK9, and it increases the number of LDL receptors clearing LDL from the circulation. So alirocumab and evolocumab decrease LDL in adults with primary hyperlipidemia, including FH as an adjunct to diet alone or in combination with other lipid-lowering therapies. Alirocumab reduces MI, stroke, and unstable angina requiring hospitalization in adults with ASCVD. It decreases LDLs in adults with HoFH as adjunct to other lipid-lowering therapies. Now, evolocumab does a little bit of the same thing, but it is now indicated in our pediatric patient population to decrease LDL for individuals greater than 10 years of age with HeFH as an adjunct to diet and other lipid-lowering therapies, and to decrease LDL in adults and the pediatric population with HoFH. So here are the dosing. Alirocumab administered 75 milligrams sub-Q every 2 weeks. If more LDL reduction is needed, you can increase that to 150 milligrams sub-Q every 2 weeks. Or you can start out with 300 milligrams sub-Q once a month. Evolocumab, sub-Q 140 every 2 weeks or 420 once a month in an adult population or pediatric population greater than 10 with HeFH, and in the pediatric population with HoFH, you can deliver 420 milligrams sub-Q once a month, or if needed more reduction, you can increase that up to every 2 weeks. So mean percent LDL reduction with alirocumab, 75 to 150, you get an additional 45 to 58% reduction in LDL cholesterol on top of max tolerated statin. Evolocumab, 140 milligrams every 2 weeks, and 420, you get a reduction in LDL of 64 to 58%. Contraindications, just a hypersensitivity reaction to the medication. Hypersensitivity reactions are usually injection site reactions, erythema, redness, and swelling. Adverse events, alirocumab and primary hyperlipidemia, nasopharyngitis is pretty much a common side effect of both evolocumab and alirocumab. So use during pregnancy, there's no safety data, so we do recommend you avoid use. There are no drug-to-drug interactions. So with PCSK9 inhibitors, cost can be an issue for especially your Medicare population. It does require a prior authorization. Over the years, this has improved from what it started out to be upon launch. And for the commercial payers, there is a copay card that does assist with payment. And we do have cardiovascular outcomes, 15% relative risk reduction in CV death, MI, stroke, unstable angina requiring hospitalization for alirocumab. And evolocumab, you see here 15% relative risk reduction in their primary endpoint and 20% relative risk reduction in their secondary endpoints, with an absolute risk reduction of 2%. Open label extension, so the longer we kept evolocumab on the market, all your patients want to know how long has it been out and do you see any increase in adverse events? So this is an open label extension where those who were on placebo were able to obtain evolocumab, and you can see immediate reduction in LDL cholesterol, and there were no red flags showing any increase in adverse events. So our small interfering RNA, we have inclisiran targeting PCSK9. So once again, it reduces PCSK9 production in the liver, thereby increasing the number of receptors on the surface of the liver, clearing LDL cholesterol in individuals ASCVD or HeFH as adjunct to diet and max tolerated statin therapy. It's 284 milligrams sub-Q on day 1 and day 90, and then it goes to a maintenance phase of every 6 months. This is buy and bill. It's given in your clinic by a clinician. You have a mean percent reduction in LDL 48 to 52% in the efficacy and safety trials. There are no contraindications and currently no warnings or precautions. You have injection site reactions, arthralgia, urinary tract infections, diarrhea, bronchitis, no safety data in pregnancy, no drug-to-drug interactions. Currently, no cardiovascular outcomes trial, but we do have some set for completion in 2026 and 2027. This is buy and bill, so it's done a little bit differently in your office, which is new to the cardiology practice. It's a sub-Q administration by the clinician. If you have commercial insurance or Medicare Advantage plans, it does require a prior authorization, and depending upon what the out-of-pocket max amount of money is for your patient, it could be very expensive for them. If they have traditional Medicare with a supplement, it requires no prior authorization, and usually it goes through Medicare at 80%, the supplement at 20%, and all that the patient may have to pay is their Medicare deductible of $226 per year. So for our Medicare population, this may be a better approach and certainly more cost-effective. So this is just the mechanism of action that I already described to you guys. And this is our efficacy studies, Orion 10 and Orion 11, which I already discussed with you, percent reduction. I'm just going to quickly mention for our FH patients, I get more and more referrals every day about FH patients with LDL cholesterols off medication of 250, 300, 350 milligrams per deciliter. So we do have more medications for our FH patients. I mentioned the PCSK9 inhibitors. We have lamidipine, which is an oral medication starting at a very low dose. 5 milligrams can titrate up to 4 milligrams. You do have to be REMS certified, which is a safety program because it does have a black box warning for liver toxicity, but this is a choice for your FH patients. And even Acumab, which the anti-PTL3 that Carol spoke about earlier, is also, it does lower triglycerides, but it also is very effective at lowering your LDL cholesterol, which is a once-a-month infusion given in an infusion center, or home health can give it to the patient. Once again, this does need to be approved by insurance, but certainly is an effective means for your FH patients. So in summary, we talked about the outcomes, secondary prevention. My biggest thing is treat early, treat aggressive. And one thing we do know for sure, if your patients can't afford the medication versus paying for food to put on the table, then the medications are not going to be utilized. So talking to your patients about cost effectiveness and being able to take the medication in their real world is an important conversation to have. And that way we can use whatever means necessary to get them the medication that they need. Thank you.